As you all know, the today's topic is about oxygen therapy. And we all know the importance of an oxygen therapy, mainly due to this pandemic situation, where even educated and non-educated people also came to know the importance of the oxygen in our life. So here in this, we'll discuss about all different types of devices, whatever we'll use for the oxygen therapy. So I would like to ask you a question, whether into your profession, do you all know what is the difference between a nasal cannula and the HFNC? Oral simple face mask, venturi mask, and NRPM. In this session, I will assure you that we'll know the difference between all these devices. And in detail, I'm going to discuss about all the devices. Next. Yeah, I'll make sure that these all 5 steps you will come to know by the end of the session. So these steps are very much important to initiate an oxygen therapy. So firstly, we need to assess the need of the oxygen therapy. Then you need to identify the type of hypoxia. Based upon the status of hypoxia, we need to initiate oxygen administration by using the oxygen delivery devices. Then don't forget, when the patient is on oxygen therapy, we need to monitor continuously and don't neglect the complications.
This one, right?
Share the screen. Before knowing in detail about all the needs and all these steps, first I would like to discuss about the normal mechanism, how we will initiate in a breath. So when there is an increase in the CO2 levels in the blood, it will give an initiation to the brain. Then the brain will give an impulses to initiate in a breath. That is a normal pattern what will follow in all the normal patients. So before that, I would like to discuss about oxygen deprivation mechanism. So when there is a lack of oxygen supplementation, we'll observe hypoxia. Okay. So when there is a low level of oxygen in the tissues, it indicates hypoxia. Then if it is not treated, then you can observe low level of oxygen in the blood, which indicates hypoxemia. Sorry for the disturbance. Yeah, let's start with again oxygen deprivation mechanism. First level will observe low level of oxygen in the tissues. It indicates hypoxia. When you are observing low level of oxygen in the blood, it indicates hypoxemia. At the stage of hypoxemia, even will observe increased CO2 retention in the blood, which means hypercapnia, which leads to lack of blood and oxygen supply to the brain, which means ischemic hypoxia. At this stage, we will observe lack of oxygen in the tissues, which indicates anoxia, where you're going to observe bluish discoloration, which means cyanosis. So this is the main thing about the mechanism of an oxygen deprivation, where we all should be aware of, mainly about the terminology. Then, now we had done with all the things. So we'll start with all the steps now. What is our first step? Yeah, the first step is we need to identify the need of oxygen. So when there will be a need of oxygen, so the first thing about the saturation levels. What is the normal saturation levels that will maintain in a normal human beings? Yes. Yeah, let me check in the chat box who are all given the answers. The normal saturation levels. Good. It is 95 to 100 percentage. And whenever you're observing the saturation levels of 90 percentage, it's an alarm sign where we need to monitor the patient continuously. So when you observe less than 90 percentage of saturation levels, then it's an indication that you need to initiate an oxygen therapy. The next one is less than PaO2 levels. The normal is 80 to 100. If it is less than 60, you have to start an oxygen therapy. Then when you look into the severe trauma patients, what exactly is happening over there? So you will observe sorry. Yeah, we are with the needs. We had discussed till now about, as we are discussing about the need of oxygen therapy. So first is about saturation levels in the blood and also the PaO2 levels. So whenever you're noticing about any patients with severe trauma, we are noticing a heavy blood loss. So due to the heavy blood loss, the cells are in need of oxygen. So it's an indication that you need to start up an oxygen to improve the cellular metabolism so that you can decrease the mortality rate. And other thing is the main indication, it is severe respiratory distress. So in those conditions, mainly you can look into the asthma, acute asthma, or else you can go for the pneumonia. So what exactly is happening over here with the acute asthmatic patients? Yes. So in severe asthmatic patients, we will observe a mucus secretion. Mucus will be collected in the bronchi region. Due to that, we are observing a bronchoconstriction. It means the pathway has become narrowed. So the entry of oxygen into the lungs, it's decreased. So when the patient is inhaling, the less amount of oxygen is entering into the blood vessels, which is indicating for oxygen therapy. So that is how it works out with the severe respiratory distress. Then when it comes to the COPD, what do you mean by COPD? Yeah, I would like to have a quick response in the chat box. What do you mean by COPD? COPD means chronic obstructive pulmonary disease. The term itself, we are giving a clear identification that it's an obstruction. So here, what's happening means, do you remember about the respiratory drive, what we had discussed in the starting slide? So when the CO2 level increases, it will stimulate the brain and the brain will give an impulses to the lung where we are initiating a breath. But whereas here in COPD patients, already they're having a CO2 retention. Due to that CO2 retention, there will be a suppression of the hypercapnic drive. Due to that, the oxygen levels will fall down. It means hypoxic drive. So in case of an COPD patients, when there is a decreased level of oxygen levels, they will start initiating a breath. It's a reverse phenomena for the normal and the COPD patients. Increased CO2 levels, we are initiating a breath. Whereas with the COPD patients, decreased O2 levels, they are initiating the breath. This is the main difference you all need to remember. And guys, whenever you're handling a patient with COPD, don't forget you need to administer only low amount of fluid. Sorry, low amount of oxygen. Okay. Sorry for the inconvenience till now. Fine. Then next is myocardial infarction. The term infarction means it's clearly indicating that cell death. So you are supplying an oxygen to decrease the size of an ischemia and also to limit the complications. So that's all about the need for an oxygen therapy. So we are done with our first step. Then what is our next step? Do you all remember? First is need. The next one is you need to identify the type of hypoxia. So based upon the hypoxia mechanism, we're having 4 types: type 1, type 2, type 3, and type 4. So when it comes to the type 1, here there is a lung failure. It means like when you observe in acute respiratory distress or any bacterial infection, there is an accumulation of pus in the alveoli. So there is no proper gaseous exchange. So there you are observing PO2 levels less than 60 mm of Hg. Then when it comes to the type 2, here alveoli is functioning normally and even respiratory muscles are also functioning normally, but the main reason is brain, it is not giving a correct impulses. So that's the main issue. So here where you're going to observe hypercapnia. So increased CO2 levels in the blood. When it comes to type 3, mostly you'll observe in the post-operative patients. Why? Because due to the uses of the sedatives. And here the treatment will be positioning of the patient and also for the physiotherapy. Then type 4, yeah. So any kind of shock like cardiogenic, hypovolemic shock, any kind of shock will goes to the respiratory failure. And here it's a clear indication for the mechanical ventilation. Type 1, we can use all low flow devices, whereas in type 2, we'll go for the NIV. So non-invasive ventilation. So type 4 is a clear indication for the mechanical ventilation. So you all can have a look into the slide once again and you can take a snapshot of it. Clear? Yeah, we are done with the 2 steps now. We had identified the need and you had identified the type of hypoxia. Then what is the immediate step? What is the important step now? So here, the important thing is we need to initiate an oxygen therapy by using the oxygen devices. So before moving on to that, I would like to teach you about process of delivering oxygen. So what do you mean by it actually? We should know whenever you are noticing a patient with signs of hypoxia, like restlessness, headache, confusion, anxiety, or SOB, then immediately start oxygen support. The main intention is we need to reach the target rate of 97%. So if you had started with nasal cannula, but we didn't reach the target, then you can use simple face mask. Likewise, based upon the flow rate, and the main important thing, we should reach the target rate of 97%. So in spite of the supplementation, you notice the patient has landed up in signs of severe respiratory distress. So where you will notice tachypnea, or else when the patient is exhaling, you listen the grunting sounds, and when the patient is inhaling, will listen the whistling sounds, and where the patient will tend to bend forward. All these symptoms, all these signs, whenever you're observing, it's a clear indication that we need to start NIV. So with the modes of BiPAP or CPAP. Then in spite of that also, if the patient is not maintaining the saturation and it is intolerable, then we need to go for mechanical ventilation. So it's very important, based upon the flow rate, we are going to choose the devices. So it's a very important subject now. We are going to start. It's all about the oxygen delivery devices. So these are all the different oxygen devices where everyone knows low flow, mixed flow, or else high flow devices. And here in detail, we are going to look into all the devices like nasal phones, venturi mask, high flow cannula, TPs, tracheostomy, non-invasive ventilation, and ET tube. So all these things we look in detail. So let's first we look into the classification, as we are having low flow, fixed flow, high flow, and other devices. In low flow, we have nasal prawns, oxygen face mask, non-rebreather mask, and partial rebreather. Whereas in fixed flow, it is venturi mask. And in high flow devices, we have HFNC, tracheostomy collar, TPs. And in other devices, we have other resources like NIV and ET tube. So that's about the classification. You can have a note of all those things. Then let's move into our main topic of today. Low flow devices. So first about the nasal prawns, and another name for the nasal prawns is nasal cannula. By using this device, we can administer a flow rate of 1 to 5 liters per minute, and it delivers an FiO2 of 24% to 40%. And here you can have a look into the video how they are going to connect and how they are going to adjust the nasal prawns. The important thing, you should not fix the nasal prawns to the occiput region. It will cause a pressure ulcer. So you have to adjust under the chin. That is very much important. You all need to remember. And the main disadvantage of this nasal prawns is it will cause nasal irritation. Apart from that, it's for a low flow to maintain the saturation levels with the flow rate of 1 to 5 liters. It's a best option. The next one is simple face mask, where it will deliver in a flow rate of 6 to 10 liters per minute, and FiO2 is 40 to 80%. So after fixing the mask, you have to adjust the mask very clearly. Fine. Here also you're noticing it's in a normal mask. Then what is the difference between nasal cannula and the simple face mask? What is the difference that you're going to notice over here? Yeah, comparatively to the nasal prawns, you are administering a little amount of extra oxygen you are supplying for the patient. And the main disadvantage over here is patient cannot eat normally. Yeah. So now it's in a time for feed. What you're going to do with the patient? The patient is on simple face mask and it's their lunch time. Then what you'll do now? Yes. Anybody? Can I see the answers in the chat box? Okay. Yeah, that's good. Uh, you need to place a patient in nasal prones, then you can feed the patient. But the main important thing is your eyes should be onto the monitor. You need to look at the monitor whether the saturation levels are dropping down or not. That is very much important. If you notice that the saturation levels are dropping down, immediately start simple face mask oxygen. Don't waste your time. So you can inform the doctor, then the doctor may take a suggestion of rice tube feeding. So that's about the simple face mask. Then what is the next low flow devices, whatever we had seen? The next one is non-rebreather mask. Yeah. So if you observe here in the image, we are having a reservoir bag. Okay. So the main important thing, we are having a valves onto the mask. So it's a unidirectional, and the valve name on the mask is expiration valve. Okay, and in between the connection between the mask and the reservoir, again one more valve we are having, that is inspirational valve. So it will help out only pure oxygen the patient is taking. So when the patient started inspiration, the valve will get open, then the patient is taking a pure oxygen. When the patient is exhaling, the ports will open and the carbon dioxide will escape from the port. So there is no combination of any carbon dioxide and oxygen. And the main thing you all need to remember, you need to set the flow rate in such a way that when the patient is taking an inspiration, we can notice the bag may collapse. To avoid the collapse of the bag, you need to set the flow rate in such a way that the bag should be filled half or 1/3 of the bag, even though when the patient is taking an inspiration. That is important. And here we are supplying a good enriched oxygen for the patient, and it is really contraindicated for the COPD patients. Why it is contraindicated? May I know the answer? Yeah, already it has been displayed. So you might have noticed it's a hypoventilation. Why there will be an hypoventilation? So whenever you're giving, so if you notice the FiO2, it is delivered by the non-rebreather mask is 100%. So already the patient having a CO2 retention and hypoxic drive will be there. When you are giving in a high amount of oxygen by using the non-rebreather mask, there will be a suppression of the hypoxic drive, which results in hypoventilation. So you should not use this for the COPD patients. Then next device is partial rebreather mask. Yeah, here also you're having a mask, and even for the NRBM also you have a mask. Then what is the difference between these two devices? Can you make out? Yeah, if you notice very clearly, so there isn't a difference. What is that? So you just look at the image. You're having a reservoir, but you're not having any inspirational valve over here. But whereas in non-rebreather mask, we are having a valve over here, and it is unidirectional. There is no chance of mixing of any carbon dioxide and oxygen. But when it comes over here, it is like two valve. So when the patient is exhaling, even some amount of carbon dioxide is mixed up with the oxygen. So here there is a mixing of both the oxygen and the carbon dioxide. So due to that, the patient may feel suffocation. And the flow rate it maintains, it's about 10 to 15 liters per minute. And the FiO2 delivered by this device is 40 to 70%. So till by this, we had end up with all the low flow devices. So what are the low flow devices we had seen till now? May I know? Yeah. So till now we had discussed about the simple like a nasal cannula, simple face mask. Yes, the non-rebreather mask and partial rebreather mask. Then comes with the fixed flow. So fixed flow is about Venturi mask. Yeah, you might be thinking, here also we have a simple face mask type, and simple face mask is also in a mask. Then what might be the difference between simple face mask and Venturi mask? So simple face mask, you can deliver the oxygen, but here in Venturi mask, you can deliver the good concentration, fixed concentration and accurate concentration you can deliver for the patients. And if you notice the flow rate over here, from minimum to maximum, you can deliver by using the Venturi mask, that is 2 to 15 liters per minute. And the fixed, Here, FiO2 is fixed. If you notice down over here, based upon the color code, it's a fixed FiO2, whatever you're delivering for the patient. So, and whenever you are delivering, the main important thing, you can use this device for the COPD patients only when there is a need of low to moderate oxygen requirement, not more than that. So I repeat again, Venturi mask you can use for the COPD patients when there is an oxygen requirement of low to moderate, not more than that. If in case you had administered a 50% of oxygen for the patient, for in case of a COPD, then you can observe CO2 retention. It means increased carbon dioxide levels in the blood. So in terminology already we had seen, what is that? Hypercapnia. That is what you will observe in COPD patients. Clear? Yeah. The next one is high flow cannula. So we had done with our low flow, fixed flow, and its high flow devices. So in high flow devices, we are using an HFNC cannula. So I think you might be used most of the time for the COPD patients, high flow nasal cannula. Why? So how we are going to use this, and what are the important things that you should know about this high flow nasal cannula? May I know the answer? Anybody? Yeah. Here, the main important thing, 3 parameters. You should know about the temperature, the speed, how much you're maintaining, and other thing is flow rate. So these 3 things will play a vital role whenever you're using this high flow nasal cannula. And by this cannula, we are delivering a humidified oxygen for the patients. Am I clear? Yeah. So here, the temperature, why we are adjusting the temperature? To prevent the nasal injuries, we are adjusting the temperature according to a normal body temperature. Like we are adjusting around 31 degrees Celsius or 34 or 37. And the normal speed it will maintain is 20 to 60. And the flow rate it will maintain to 20 to 60 liters per minute. So here the FiO2 has been calculated by the machine itself. You are not going to adjust anything. The next device is tracheostomy collar. Yeah. What do you mean by the tracheostomy collar, and in which all conditions you are going to use a tracheostomy collar? Mainly, when the patient is on tracheostomy, we are going to use this tracheostomy collar to deliver the oxygen, or else even the tracheostomy collar, even we will use with the Venturi mask as well. So what actually it will do? It will give an accurate FiO2. Then what? Yeah, it will maintain good humidity. So mainly in chronic chronic O2 therapy, we are going to use this tracheostomy collar. The flow rate maintained by this is 10 to 15 liters per minute. And the FiO2 delivered by this therapy, by this device is 35 to 60%. The next one is T-piece. Yeah, I think everyone might be known about this T-piece. When you will use this T-piece actually? Yeah. So when the doctor is planning for the extubation, first the doctor will place the patient on T-piece, either on tracheostomy or on ET, ventilation. So the preferable is T-piece. And here we will be using this T-piece only for a short period of time. So when you are placing the patient on T-piece, you will come to know whether the patient is initiating the breath or not. That is the main importance of the T-piece. So whenever you're using the T-piece onto the high flow rate, it will consider it as a high flow device. And the rate it delivers about 8 to 15 liters per minute, and FiO2 21 to 100%. Then now we are done with all the devices, and other devices it includes non-invasive and ET. So in non-invasive, we are having 2 modes, that is CPAP and BiPAP. So CPAP, what do you mean by CPAP? CPAP means continuous positive airway pressure. So in continuous positive airway pressure, what exactly is happening with the patients? So you are administering continuous pressures into the lung where the alveoli is being opened and widened continuously. So what happens exactly when the alveoli is open? So there will be an exchange of gases continuously. So the same thing is happening over here. When the patient is on CPAP, there is a continuous exchange of gases, and mainly you will use it for the obstructive sleep apnea and pulmonary edema. Initially, we'll start with 3 to 5 centimeter of water, and if there is no change in the saturation, you will raise up to 10 to 15 centimeter of water. The next device is BiPAP. What do you mean by BiPAP? It's in a bi-level positive airway pressure. So it will make the lung to function normally, like inhalation and exhalation. So where we are going to set the IE ratio. So inspiration should be always more than the expiration value. So inspiratory pressure is 5 to 10, whereas expiratory is 5 centimeter of water. That is how you're going to adjust. So mainly used for the patients with COPD, weaning, neuromuscular weakness. So that's about the CPAP and BiPAP. Then the last device is ET. You all know, already we had discussed. So when we'll go for the mechanical ventilation, if you remember the process and also the type, you can easily say when you will prefer ET tube or mechanical ventilation. Yeah, in type 4 respiratory failure, we'll go for the mechanical ventilation. And then any other answers? Okay, so two things mainly. When the patient is not when the patient is in severe respiratory distress syndrome and continuously, even on NIV, the patient is not tolerating, then we'll go for the mechanical ventilation. And other thing is type 4 respiratory failure, we'll go for the mechanical ventilation. And regarding this in detail, we'll look in the next session. So now we are done with the 3 steps. Then what is the 4th step? Do you all remember? We are done with your what? Need you had identified. You had identified the which type of hypoxia it is. Then you had known about the initiated the therapy. Then when the patient is on oxygen therapy, what we need to assess from our end, what we have to monitor. Can anyone give me the answer regarding this? Okay. Good. You have to check the saturation levels. Fine. You need to observe for the respiratory rate. Fine. Fine. Very good. So let's look into that. We need to assess the type of breathing pattern as well. Why we need to assess? Whether the patient is using the accessory muscles or else shallow breathing, what type exactly, whether the patient is maintaining normal breathing pattern. All these things we need to assess. Then as you all told, you need to check the respiratory rate, chest expansion, saturation, whether the patient is maintaining or not. And even we need to go for the ABG analysis. And the last, if you notice over here, it's about you need to check the sensorium. Why it is important to check the sensorium? Do you remember our first slide, like oxygen deprivation? We heard about like ischemic hypoxia. What actually happening there? There's a lack of oxygen and blood supply to the brain. Due to that, there will be an altered sensorium. So when the patient is on oxygen therapy, we need to even check the sensorium as well. Clear? Then last but not the least, complications. So what about the complications over here? So complications or side effects of an oxygen therapy. So when there is an oxygen toxicity, so oxygen toxicity means what? So excessive amount of oxygen you are giving for the patients, then you will notice these signs and symptoms like substernal chest pain, vomiting, headache, fatigue, nasal stiffness, non-productive cough. And other complication is absorption atelectasis. What do you mean by that? Okay. Anybody? You can just type your answer in the chat box. Okay. Collapse of the lung. Fine. Actually, it's a clear meaning that you need to say it's a collapse of the alveoli. So as you're giving an excessive amount of oxygen with a pressure into the lungs, it is just going for the nitrogen deprivation where it will lead to the collapse of the alveoli. So collapse of the alveoli means atelectasis. Clear? Yes. Now we are done with our session. Okay. If you're having any doubts, you can raise it, pose a question in your chat box.
Good presentation, Hema Bindu. You made presentation very simple and understandable. Hope everybody followed this discussion, and you must be knowing by this time what are the importance of different oxygen delivery devices in a better clinical outcome, in which condition, in which medical condition we should use which device. So we have trying to cover basic things. So next topic we are going to take on ventilator. So now we are with us, our senior consultant anesthetist, intensivist, Dr. Durgesh is with us. He would like to give us just brief on the oxygen therapy.
Good afternoon, everybody. So now you must be, after this talk, you must be knowing that how oxygen is important. So oxygen therapy, as already know, if we want to maintain the normal saturation of say 95%, more than 95%, you consider the normal oxygen saturation. In the ICU, when the patient comes or when the oxygen requirement goes high, that indicates that the underlying disease process is worsening. So initially the patient is maintaining on some form and room air and is requiring more and more oxygen. That means that the underlying disease process or patient has developed a new disease process. Say patient came with the pneumonia and is requiring progressive increased oxygen requirement. Initially he is on nasal prong, which gives approximately 2 to 4 liters of oxygen, so that if it is increasing progressively, that means that underlying disease process is worsening. You have to act fast. You have to inform your doctor. You have to increase the therapies in form of antibiotics or any other devices. The other thing is that also indicates, suppose any cardiogenic conditions, that pulmonary edema might be worsening. That is also indicates that your oxygen therapy is, or your progressive requirement of oxygen is going on increasing. Say already discussed, there are various therapy devices available, which range from nasal prong down the line to HFNC to NIV to the mechanical ventilation. These these devices provide different oxygen concentration, different oxygen depending upon the patient's requirement. Suppose the patient is requiring minimal oxygen, especially in the COPD patient. What happens in COPD patient? The drive, as already been discussed, the drive is not hypercapnia, it is a mainly hypoxia. So if you go on giving in oxygen to these COPD patients, so what happens is their hypoxic drive will go down, and there are chances that the patient will end up in CO2 retention. So in COPD patient, just target 88 to 92% of oxygen. So in that situation, what we can do, you can start up with the nasal prong. If not required, you can start a Venturi mask. So coming to the Venturi mask, what is meant by Venturi mask? Venturi mask relies on the Venturi principles. So what happens is, it is a Bernoulli's principle. So if we give fixed flow of oxygen, there is an entrapment port are situated. The entrapment ports, what they does is, they allow fixed amount of atmospheric oxygen to enter into the devices. So if you are giving particular flow, so for example, if you are using a green colored Venturi mask, so the flow rate required is minimum 15 liter per minute. So it will give 60% of oxygen, 60% of FiO2. The remaining 40% will be the atmospheric air which is going. Thus, the fixed amount of oxygen to be delivered to the patient. And these devices are used when the patient's breathing, work of breathing is suppose at an acceptable range. When there is progressive increase in the work of breathing, so you have to increase your ventilatory support in the form of either HFNC or in the form of BiPAP or a CPAP. And finally, when the work of breathing is too much or the demand of the patient is too much, then you have to go for mechanical ventilation. Coming to the HFNC is recent introduction in our treatment for the hypoxia. The basic concept of HFNC is, with HFNC we can do high flow up to 60 liters of oxygen. Previously, what was the problem was, if you see nasal prong, one of the disadvantages is, so there is no humidification of oxygen. Patient should feel suffocation. So with HFNC, we have got humidification, so you can give up to 60 liters per minute. So the patient will be awake, patient will be free to speak, patient will be able to take it, patient will be able to communicate with the attendant, but simultaneously he is getting almost 100% of oxygen. That is the advantage of having HFNC. Suppose on that also your work of breathing is worsening. That means that patient is having persistently worsening pneumonia, or persistently patient is having edema, or which is not responding to our conventional therapy. When you want to increase your support, then there comes in the picture of like CPAP or portable backup. What it does is, apart from HFNC, the added advantage here is, it will give a PEEP. PEEP is what? It is a positive and expiratory pressure, which opens your collapsed alveoli. So there will be more and more surface area which is available for the oxygen exchange. So here it also is the work of breathing, especially in COPD patient, where the CO2 retention is there. We want to wash it out CO2, so we have to increase the minute ventilation. their CPAP, their BiPAP can be easily used. Other indication of BiPAP are cardiogenic pulmonary edema, where also we want PEEP effect, or patient is having neutropenic type 1 respiratory failure, neutropenic patient developing pneumonia. Their intubation may not be that much indicated. Why? Because they are already immunocompromised. If you are intubating patient, there are again development of new infection, hospital related infection. So the again mortality may increase. So NIV is the temporizing measure to ease their work of breathing. Finally, if the work of breathing is still not being controlled by the devices, if persistently worsening of hypoxia, the final is the mechanical ventilator, where you can give 100% of oxygen, where you can give almost controlled mechanical ventilation, where other parameters of your ventilation like P, plateau, they are controlled. Even that also, if you are not able to control your on-down ventilator also, you are not able to control, then other option is like you have seen in ARDS patient or in COVID patient also. We have a lot of tried a prone ventilation. Okay, prone ventilation, what it does is it is going beyond some discussion, that prone ventilation, it recruits your alveoli in dorsal part of the lung. So the more gas exchange, more surface area is available for the gas exchange. Suppose on that also your oxygenation therapy, your support is increasing on that. Then finally we have support of ECMO, extracorporeal membrane oxygenation. We have what where primarily the respiratory pathology, where we'll put a venovenous ECMO. When it is a combined both cardiac as well as respiratory pathology, we use a VA type of ECMO. So this is the overall nutshell your oxygen therapy and different oxygen devices. So any other question, we are happy to answer.
Thank you, sir, for your brief orientation on oxygen therapy and oxygen different devices and application of those in different medical conditions. So we'll be getting this kind of good topics with good speakers. Be log in with us every Friday 3 p.m. Thank you, everyone. Thank you, Bindu. Thank you all. Thank you.